I will switch. I'll switch to English now. It's a great pleasure to introduce Professor Peter Ringleb, Professor of Neurology at Heidelberg University Hospital, to you that he found the time to prioritize to speak for us the Stroke Unit 2021. The Heidelberg flavor is the title of his talk. Peter Ringleb is the cerebrovascular star in Germany, at least my star. We are. Heidelberg is the reference center in Germany. And I will come back to that a little bit, because I got my specialty and my education in neurological education in Germany, in Düsseldorf, and always when something new happened in the world or in Germany, it was coming from Heidelberg. And Peter Ringleb is the research leader in Heidelberg. He is responsible for the stroke treatment in Heidelberg. And as well, when I moved to Stavanger, I kept the tradition that I experienced in the starting phase in Stavanger, when we established endovascular treatment, things like that was kind of challenging for me as well, because I didn't know what am I doing now? Is that right? We didn't have evidence as well, so much. So I contacted Peter quite often in the starting phase. And actually, I don't know, he didn't know me by that time, I guess, because I was not famous as he is. But I got an answer, I think 10 minutes later on, with a quite decent explanation, and he followed me all the time, and I really appreciate that follow-up through all these years, Peter. And I really appreciate that you talk to us now and give us a little bit of the Heidelberg flavor to our Norwegian stroke organization. The talk is yours, Peter. Thanks a lot.
Yes. Dear Martin, thank you very much for the kind introduction and the very nice words. First of all, I would like to apologize for not being with you in Bergen. It's almost 10 years ago that we visited with my wife the Bergenkonferensen, and really I would have liked to repeat this. However, you know, there's a little thing coming up in the last 2 years which made it really difficult to make travel plans. And when we discussed in August about if I would like to come to Norway, or if I would be able to come to Norway, I decided to go to Venice this autumn, which we visited a week ago, which is very nice without all the Japanese and Chinese tourists. But unfortunately, I was not able to fly to Norway. And yesterday we had a large storm here in Germany, so even I would have planned to come to Bergen, I'm not sure if I would be there right now. So my disclosures, it's very realistic that I do not have any financial disclosure with this talk. My most relevant disclosure that I work for more than 20 years, the picture links left comes from 24, and the right one is more actual. So I think I'm a little bit influenced by working here. And the reason why so many things came from Heidelberg was Werner Hacke, who trained me for more than 20 years. When I planned this talk, I come to the idea that I would like to discuss within the next 45 to 60 minutes the implementation of the stroke pathway here in Heidelberg. And again, at the beginning, I would like to point out that Werner Hacke was a guy who initiated the first steps here in Heidelberg in the end of the 1980s, so now more than 30 years ago. However, when I saw your very interesting program of the last and the present day, I was quite sure that I will follow this statement of a famous German artist. However, I will try to give you some insights from the steps we are making in Heidelberg and how we have organized our stroke service, especially with the focus on endovascular treatment, which definitely has changed a lot in the treatment of acute stroke patients. Some geographic information at the beginning. Heidelberg is a middle-sized town, 140,000 inhabitants, 25,000 of them are students in the southwestern part of Germany. And this is the most famous part of Heidelberg. This is the castle. Again, because of Corona, much less visitors than the years before. So it's also for Heidelberg inhabitants now nicer to live here. And in this map, you see in blue the spot where Heidelberg is, and in red, this is the area where we receive patients, especially for specialized vascular treatments by our neuroradiologists. So almost 1 million people are living there. What about my university? The medical faculty of the Heidelberg University was founded in 1388, which is the oldest one in Europe and the oldest one in Germany and the second oldest one in Europe. There work around 13,700 people in the university hospitals, I have to say, because we have some locations here in the nearby area. Around 1,700 of those are physicians, and they run around 1,900 beds. The neurological clinic is placed in the so-called Kopfklinik, which is a hospital or a building where all the departments who cares for patients with diseases on the head within one building. And the neurological clinic consisted of 2 departments. The one is the Department of Neurology, where I work in, with more than 100 physicians as colleagues. Not every one of them is working as a clinician. A couple of them, a larger couple of them, is working in science. We are running 6 wards, and one of them is a stroke unit with 20 beds, and another one is a neurological ICU with 10 beds, and there are 60 other beds for regular wards. And we have also within the same clinic a department of neuroradiology with a lot of physicians. More than 50 are working right now there, and they are running 4 MRI scanner, 1 only for science and 3 for clinical routine, 1 own CT scanner only for neuroimaging, and they are running 2 angio suites. So we have a wide luxurious situation, I think, especially with our neuroradiology. Coming back to the pathway, you know, the first and important step is to recognize that the patient has a stroke, or that the patient recognizes that he has a stroke. And this is the most difficult step, I think, on this pathway, because if the patient does not react and does not call the right person, nothing happened. And for Heidelberg, we have initiated by our city and by our administration a stroke network more than 15 years ago. And members of these networks are representatives of the city administration, which helps a lot. Several acute hospitals, rehab facilities, also insurances, which is really important. Some neurologists from the field, therapists, social workers, nurses, and certainly very important, the support groups of the patients. And we met, I have to say, 3 times a year at least in the last years. Again, because of this small virus, anything has changed. It's not so easy to make video conferences with all those members. So the next meeting is planned for December. Hopefully it can be made. And importantly, we have organized 1 public campaign per year to teach our, hopefully not patients, to teach our inhabitants here in the area about stroke symptoms. And on the 4th, we have created a homepage, and we have published a brochure which we hand over to patients, relatives, and interesting for free, and which are also available in the townhouses here in the area. In addition, we have created the FAST consortium, which is a stroke consortium with professionals. FAST is not really the wording you know from the FAST test. It comes from the German word Schlaganfall Consortium. We have looked a little bit to find the right letters. This Schlaganfall Consortium is sponsored and was founded by the Dietmar Hopp Stiftung. This is the same sponsor with, which is sponsoring one of the German football league, Bundesliga football clubs, the Hoffenheim. So one of the richest people in Germany, and he helps us a lot to implement this network. And one part of this network certainly is also a lay information process. We have published some posters, some in the newsletters, some things. We have prepared some cards, which again you can't find in the entire hospital. And we certainly do also within this FAST network, we do some public campaigns. So these are the 2 major things we are doing to inform our public community. The second step in the stroke pathway is the emergency call. You know that it's very important that the people know how to act, and we try to teach them that if they think they have stroke symptoms, that they directly call the 112, which is also in Germany the number of the emergency service. It shouldn't call the general practitioners, but directly the emergency service. And then going straight to the next step, which is the acting of the emergency service. Here I show you now the map of the members of the FAST Stroke Consortium. In red, you see the centers which are able to perform endovascular stroke treatment. I will come to this a little bit later on because not every center does this on 24/7. In yellow, you see the centers with the smaller stroke units who can do IV treatment 24/7. And in gray, you see the centers which are collaborating with us, which send us sometimes patients, but much more important, who receives patients after the acute treatment. When I try to compare this on the scale with a region around Bergen, this is an area in almost the same size, but I think there might live less people than living in our area, which is around 1 million. What we have implemented with our colleagues from the emergency service is, like many other colleagues in the world did, we try to find a scale. Jan Puroka, one of my colleagues, was very active at doing that. We tried to find a scale we could use to identify, on the one hand, stroke patients, and to graduate, on the other hand, the severity of a stroke. So not to use two scales like the FAST scale and then on the NIH stroke scale, but to have only one scale. And again, together with our emergency service here from the University Hospital, as well with a lot of paramedics, we evaluated the items of the NIH stroke scale, and we came to 7 items exactly created as we know from the NIH stroke scale to be able to identify patients, which means a level of more than 0. And if you have a level more than 5, you know that it's a severe stroke. And this scale works very comparable to all of the other scales which have been published in the recent years. And as with all these scales, the sensitivity and specificity is not high enough to definitely rule out patients who might not have major intracranial vessel occlusion, or on the other hand, to clearly detect patients who have this. We have recently published, or it's now 4 months ago, that we have published the updated German stroke treatment guideline, which is the guideline for the acute stroke treatment. And one part of this guideline was to evaluate if there are some recommendations, if such scales could be used to help to decide which patient should be transferred to which hospital. And you know that the science is, or the evidence is very low, that so we have only very low graded recommendations. The first is that we can't not recommend any specific clinical scale to use to identify patients. The second recommendation says that since there is no clear evidence of the superiority of any of the organizational models like trip and ship, mothership, or trip and drive, the choice of model should depend on the local and regional service organization and patient characteristics, which means that you and we had to decide and to discuss with our local EMS services, and it's at least 4 emergency services here in the Heidelberg area, which sends patients or brings patients to us. If we should use a scale, which scale should be used, and how should we act on a specific scale value? And we used also the third statement that as an idea, if you have patients who live close by, 30 to 45 minutes as an example, they maybe, if they have a larger stroke, should be transferred directly to the endovascular stroke center. And if the patients live more away from such a center, it's better to bring them first to a smaller stroke unit where they could be treated with IV treatment and then be transferred in the second step. I have to exclude that this slide is still in German because this is a pre-hospital stroke care system for our emergency services. It's not so very important. The major thing is that we have used this shortened NIH stroke scale to help the colleagues, to give them an idea which of those patients should be transferred to a larger center, which is an intervention center, or to a smaller one, which is called partner center, which means a small stroke unit capable for IV treatment. I have not told you before that we also trained the paramedics using the scale, so it's not necessary that a physician is always going or driving to an acute stroke patient. The paramedics are easily or it's easy for them to do this scale. It's not very problematic to detect paresis. All the more difficult things like neglect, oculomotoric disturbance, and all those things have been skipped from the scale. So now I come to the biggest part of my talk about the stroke unit system here in Heidelberg. What happens when the patient is arrived in our hospital? First of all, they do not come to the stroke unit directly because we have, let me say, the luck that we still have an own emergency room for the departments of this Kopfklinik. This building was built 25 to 30 years ago, and at this time, the larger departments, the medical department and the surgical department, were far away 1 to 2 kilometers from the neurology department. And therefore, we got an own emergency room, and we've seen this emergency room around 14,000 neurological patients per year, and around 1,800 of them has a stroke. And to give you an idea about the staff we place in this emergency room, 1 senior physician and 1 trainees are there at daytime, so from 8 a.m. to 8 p.m. And during the night and on the weekend, we have first an on-call service from the entire staff. And in addition, we have a 24/7 teleneurological shift system, which also helps in the emergency room. And the emergency room is placed very close by to the neuroradiological department in the hospital. So it's our place where we do the diagnostic and where we start also the acute treatment. For example, IV treatment is very rarely done on the stroke unit. It's mostly done on the emergency room. And then it's decided if the patient is fit enough to go to the stroke unit, or if she or he has to be transferred to the ICU. And sometimes you will see it if I show you the numbers of our stroke patients later on. We also discharge a couple of patients directly, for example, TIA patients who got an ultrasound, who got a CT, maybe a CT angio, and also an ECG and the lab tests. They are not very rarely discharged directly. And we cooperate with a couple of hospitals. Thus, patients who do not need our specific treatment sometimes are discharged to other hospitals or to other stroke unit in the area around. Regarding the stroke unit admission, it's very easy. In our recent guideline, we wrote that all acute stroke patients should be treated on a stroke unit. And we explained that the advantage of the treatment on the stroke unit applies to all stroke subtypes, irrespective if it's a TIA, an ischemic stroke, or an intracerebral hemorrhage. And also for patients with subarachnoid hemorrhage, it's better to be treated on a specialized stroke unit as compared to a regular neurological ward or medical ward. And very important also for Germany, it's independent of the severity and regardless of the age. We sometimes have difficulties with our insurances if we treat patients above the age of 80 or 90. They sometimes try to start the discussion if this is useful for those patients, and it's quite sure that it definitely is. You know that especially elderly patients benefit from specialized treatments. In this guideline, which is a modification as to previous versions, we adapted the statement from the Canadian guidelines regarding our patients with TIA symptoms. And we recommend that patients with TIA symptoms within the last 48 hours should be treated on a stroke unit, that patients with symptoms more than 14 days or 2 weeks ago, an outpatient evaluation might be sufficient. And if the patient comes, which is not very uncommon. Had a TIA on Saturday, but goes to the GP on Monday and comes to us on Tuesday. We always have to think, it's now their need to transfer them to a stroke unit, or can they be treated outpatient or on a normal ward? We have formulated some criteria like high recurrence risk as measured with ABCD2 score, or known AFib with an insufficient anticoagulation, or known stenosis of brain supplying arteries or something like that, that those patients should also be treated on a stroke unit. The German concept of stroke units is rather old. It was initiated in the end of the 90s and updated in this paper in beginning of this millennium. It should be a defined part of a hospital which is specialized for the treatment of stroke patients. The most important thing is that there works many members from a multidisciplinary team with specialized staff, with many nurses, physiotherapy, occupational therapy, speech therapy, and psychologists, social worker, and beside neurologists, also internists. An instrumental monitoring should be part of the stroke unit, and the stroke unit should be doing the diagnostic and the treatment for stroke patients and should start the early rehabilitation. This is a concept which has been written by the German Society of Neurology, as I mentioned, more than 20 years ago. So the stroke unit in this concept is something like a hub for diagnostic and therapy. It starts with monitoring, specific therapy, early secondary prevention, and consists also a couple of enclosed societies and colleagues from vascular surgery, neurology, neurosurgery, cardiology, and so on and so forth, to keep care for the patient in the middle of the spider net. Also, again, a very luxurious situation regarding the stroke units in Heidelberg, in Germany. This comes from the Deutsche Schlaganfallhilfe, which is a lay people organization helping us to certify the stroke units. And 1 year ago, we had almost 330 certified stroke units in Germany. You might know that we have different levels of stroke unit. Here in with this red circles, you see the sogenannten regional stroke units, which means that the smallest stroke unit usually not doing endovascular stroke treatment, and we have 133 stroke centers usually are able to do endovascular stroke treatment, and also especially in the southeastern part of Germany, we have a couple of tele stroke units. Just very short reminder regarding the efficacy of the stroke unit. It's almost 8 years ago that Peter Longhorn has published this systematic review and meta-analysis clearly demonstrating that a treatment on a modern stroke unit reduces risk and death and dependency for patients with ischemic stroke by 21%, as well for patients with intracerebral hemorrhage by 18%. And if you look only for the endpoint mortality only, then it's especially effective for patients with intracerebral hemorrhage to be treated on a stroke unit. What about the Heidelberg systems? If we got visitors and I show them the stroke unit, I always have to tell them that there's not much to see. You see this ward, the door to the ward, and I will show you on the next slide how it looks like behind this door. Then usually there's nothing. And then it starts that you see a lot of colleagues running around, but there are no big machines. We have the monitoring beside every bed. We have an internist, we have a cardiologist. We can do the ultrasound, but it's as compared to a department of surgery or radiology, there's no big machine you can see. So again, I think there's not much to see. It's more concept than really something you can demonstrate. I have mentioned in the beginning that our stroke unit has 20 beds. Following our certification by the German Stroke Society and the Stiftung Schlaganfallhilfe, 16 of these beds are named stroke unit, and the other 4 are so-called semi-intensive care unit beds, which has something to do with the amount of nurses we have. And there's a formula given in the certification process, and then you can calculate how many stroke beds and how many semi-intensive care unit beds you have. all of these beds have the same monitoring, so we can treat up to 20 acute stroke patients, but sometimes we have only 10 and 6 patients with seizure status, or 2 patients with a subarachnoid hemorrhage, and so on and so forth. So other with Guillain-Barré syndrome, so other patients who can benefit from a specialized ward treatment. In the last year, we have treated together with the ICU, though together with the 10 beds of these colleagues, 1,140 ischemic stroke patients, 240 ICH patients, and 170 TIA patients. So you can see there's a little gap as compared to the 1,800 patients I explained you earlier, and those patients have been discharged or transferred to another hospital from the emergency room directly. And thirdly, we see more than 172 TIA patients in our hospital, but a lot of them are not admitted to the stroke unit in our hospital. The mean length of stay of the stroke patients in our department, not on the stroke unit, our department is 5.1 days, sorry. In the stroke unit, the mean length of stay is around 3 days. What about the staff on the ward? It never has been possible to make a picture of the entire staff because some are working, some are away. So it's only a very, very small proportion of our staff you can see here on this slide. On our stroke unit works 2 senior physicians on a 50-50 base, so 1 per week. We have 2 specialists who work there also on a 50-50 base. So 1 is doing research and the other is working on the ward. We have 5 trainees for neurology on the ward. They're doing a 24/7 shift service, and they are responsible only for the stroke unit. And at night, they keep care for one of the other regular wards. So we have 2 other shift systems in the hospital. 1 is for the ICU and 1 is for the emergency room and the teleneurological service. So a lot of staff is working here in our hospital. We are very happy and very lucky that we have also 1.6, so 2 women, as you can think, specialists for internal medicine, including cardiology on the ward. So we can do all the echoes on the ward directly. Patients have not to be brought to the cardiology department, and also, so it's very easy for us. And this is also based on the tradition introduced by Werner Hacke, that when we started our stroke unit in 1998, the medical department was 2 kilometers apart, and then we bought 1 internal medicine from our cardiologists, and this has been replicated a couple of times. So we still have them on the ward directly, which helps a lot. I mentioned a lot of nurses. We have on average 29.6 nurses for the entire ward, and we aim, it's not always possible, especially in Corona times, it was not possible to do it all the time, but we aim to have 6 nurses in the morning, 5 in the afternoon, and 5 during the night, and no difference if it's Monday or Sunday. And we have 7 days a week colleagues who are doing the physiotherapy, the occupational therapy, and the speech therapy. So as it is wished by my society, we have realized it now that patients can really get their early rehabilitation from the beginning of the stay in the hospital. I would like to give you some ideas about the monitoring, especially the instrumental monitoring we're doing on the stroke unit. Therefore, to repeat this slide, that this is part of the monitoring treatment system. The guidelines recommend that acute stroke patients, and because it's a guideline for ischemic stroke, in the parentheses, it's only TIA and ischemic stroke mentioned, but certainly that is also true for patients with intracerebral hemorrhage, that those patients should be technically monitored for at least the first 2 or 3 days during the stay in the clinic. We wrote the statement that the length of stay in the stroke unit should be based on individual patient-specific considerations and consider also factors such as stroke severity and etiology, existing deficits, for example, dysphagia, complication, and comorbidities. And we do not want to give an upper or a lower limit for the length of stay. We have nearly in any patient a discussion with our insurances. You know that we are paid in according with the so-called diagnosis-related groups or DRGs. And one factor which is always a matter of debate is, was it necessary to let the patient 3 days on a stroke unit? Wouldn't be 2 days also enough? And if the insurance starts this discussion, you know that 2 days would be much cheaper than 3 days. It's not, there is no evidence to say 3 days are better than 2 days, but you know, there are a couple of factors like, for example, in high-graded symptomatic stenosis, where you really want to have that the patient is treated on the stroke unit longer than 1 or 2 days. What should be monitored technically? The instrumental monitoring should include at least blood pressure measurement, heart rate, ECG, respiration, oxygen saturation, and body temperature. And those who measured intermittently should be taken at least every 4 hours. It's a so-called expert consensus or good clinical practice, how it was called in earlier times. Where does this come from? This comes from also from the money. As I mentioned, we are paid by the DRGs, and one part of the DRGs are the so-called OPS, so this, the operations on procedure keys. And there has been defined 15, 20 years ago, also the complex Behandlung, the neurological complex treatment of the acute stroke. And there is written that you have to measure 6, or there it was written, this years it has changed, but in the years before it was written, you have to measure 6 parameters, like I showed you here, at least every 4 hours. And in addition, you have to do a neurological exam at least any 6 hours, but at night you can do it every 8 hours. And that is the reason why we do 4 neurological exams per day per stroke patient on a stroke unit, and why we measure all these parameters every 2 hours. It's recommended to do it every 4 hours, but if you forget to do one parameter, for example, you have measured 5 times the blood pressure, but you have forgotten to do it the 6th times, then this day is not paid. Very easy. So we measure it 12 times a day, and if you forgot one, you have 11, which is enough to have more than 6. So sometimes it's not very scientific what we are doing, but it's also not useless not to get the money for the things you are doing. So as I mentioned, within our clinic, we have also the second department of neuroradiology, which is certainly very, very important for us. And together with the colleagues, we have prepared and updated this regularly, a standard scheme for the recanalization therapies. It depends on if the disease is in the anterior, on the posterior circulation. We try to include all the science regarding the usual plain CT IV treatment, which we are doing since 1996, or the newer publications like Dawn and Diffuse, or the Wake Up trial, and also the ECAS-4 trials and the Extend trials. So a little bit complicated, but it helps the colleagues in the emergency room and also in the discussion in the teleneurological system, how patients should be treated. And a lot of patients are treated endovascularly in our hospital, which is shown on this slide, shows you some numbers from the last 9 years. As almost everybody, we have increased our numbers after the publication of the 5 trials demonstrating the beneficial effect of endovascular treatment. And since 2017, we have reached a rather high number of more than 500 recanalization treatments per year. Then in blue, that's the number of patients treated IV only. And you see that this number is decreasing more and more because those treatments can also be done in the smaller stroke units in the hospitals I showed you on the map earlier. And a lot of patients now stay there, which have been in earlier times transferred to Heidelberg to get IV treatment. This is not more necessary, though IV treatment can be done in other hospitals as well. But we are one of the hospitals who do the endovascular treatment 24/7. we have at least 8 neurointerventionalists here in the department. So it's we can really do it at least one at any time, and it's not so rare that we do 2 interventions in parallel. And therefore, the number of patients who are treated endovascular is decreasing by year. And since almost 2 years, it's now that we can offer such an recanalization therapy to more than 50% of the patients we see in our emergency room. This slide shows you the relative amount of recanalization patients in blue as compared to the entire number of patients with ischemic stroke, so only with the ICD code 63, so no TIA, no hemorrhage. But in the last year, 53% of all these ischemic stroke patients in the emergency room, not in the stroke, then the proportion would also higher, but in the emergency room, so more than 1 out of 2 have been treated by IV or IA or the combination. I know that Martin has worked a lot in training IV treatment and in doing it without patients, so a simulation. And we also took part in some simulation studies because we observed since a couple of years no more decrease in the door-to-needle time. I don't know, it's real, it's not fake, it's real that we have in the last 4 years exactly the same median for our door-to-needle time for the IV-treated patients of 33 minutes. I really would be happy if we come down to 25, something like that, but it's really difficult. Maybe because also that many of the patients we received for IV treatment have patients with a lot of contraindications, with extended time windows, and on and so forth. However, this is something which is not perfect from Heidelberg. And I also wanted to show you something which is not perfect in Heidelberg. Very briefly, some baseline data of the patients from the last year which have been treated with intravenous therapy. It's the left column, or with bridging therapy, the middle column, or with endovascular stroke treatment only. As I mentioned, many more patients endovascular than IV. The median age is higher than in the usual stroke study. You know that the median age in almost any acute stroke treatment trial is 68 years. So especially for our endovascular service is much higher, up to 78 years in median. I don't know why we treat less women by IV only than we do it endovascularly or in combination. We treat a lot of patients with existing premorbidities, which is one of the explanation of the result slides I show you in the next one. Thirdly, there's a huge difference regarding the stroke severity. In our department, if you can see an occlusion on the CT angio, more or less regardless on which part of the vessels, usually the patients goes to endovascular stroke treatment. So MT is definitely standard. A couple of M3s, anterior, posterior artery occlusion, very likely that these patients are treated endovascular in addition. And certainly, as I mentioned, few patients sent to us from other hospitals for IV treatment. A couple of them were sent with the aim to do it endovascular, but in the meantime, it came to a recanalization. So we kept the patients for 2 days on the stroke unit for the monitoring after the IV treatment, but there was not a need for an additional. And for the patients who are treated endovascular, more than the half comes from remote hospitals. This is a result slide from the last year, also not perfect. We have really a high mortality. This is a mortality rate of more than 30% in the patients who have been treated IA only. But to be treated IA only is something like a surrogate for large amount of comorbidities. Otherwise, the patients would have been treated with a bridging approach. And if you look for our bridging patients, then the mortality is only 20%. And this is comparable to the Hermes collaboration, for example. And certainly the patients who are treated IV only are much better because they are much less affected than the patients treated also endovascularly. As a specific part from Heidelberg, we do not only ship patients between the stroke centers or the stroke network, but we, for at least 3 centers, which is Ludwigshafen in the west, Rastatt in the south, and Schwäbisch Hall, another town, 70 kilometers apart. We trip the neuroradiologists. So if they receive a patient with a large intracranial vaginal occlusion, they call the neurologist and the neuroradiologist in Heidelberg, and then we start a discussion, should the patient be transferred, or sometimes the doctor takes a taxi and a suitcase with all the catheters and drives to these hospitals. And Martin Benchus, which is the head of our neuroradiology department, has published a paper demonstrating that regarding the symptom to treatment time, this ships a doctor in our area is sometimes, or on average, faster than to ship the patient. I'm not quite sure how it is in Norway. In Germany, it's a pain. If the patient arrives, for example, here in this hospital, or let me say this hospital, because the stroke unit here in Sinsheim, where, for example, Hoffenheim has its stadium, to come back to the Dietmar Hopp Stiftung. So the stroke unit in Sinsheim is run by colleagues employed in the University Hospital of Heidelberg. So we have a very close collaboration. However, if the patient is transferred there and needs a secondary transport to Heidelberg, it sometimes needs more than 2 hours, because the secondary transport has not the same priority level as the initial transport to the hospital, which is really an obstacle in the endovascular stroke treatment system in entire Germany. And this is one of the biggest problems we have to solve within the next years. So 3 or 4 slides regarding rehabilitation and prevention. We do not have an own rehabilitation department at the University Hospital. Certainly we do have, and we are lucky to have that, a couple of rehab hospitals in the area. The biggest one is the Schmieder Clinic, which is a large company running 7 to 8 very large-scaled neurological rehab hospitals in Southwest Germany. And it's very good collaboration, and we are very lucky that we can send a lot of patients and quite early also to these rehabilitation centers. And another cooperation, which is the so-called Bethanien Krankenhaus, which is a geriatric hospital, is very important for us, because I showed you the number, the age of our patients treated endovascularly, and you can imagine that in the last years, the median age on the stroke unit has risen more and more. So it's definitely not a surprise that we have patients 90, 95 years of age on the stroke unit. And if you wouldn't have a geriatric hospital taking a lot of those patients, we would not be able to care for new patients. One other problem in our hospital is a prevention strategy, which is a clear deficit. We have a small outpatient department where we can see around 20 patients per week. So this are something like 400 per year, which is not a fourth of the patients which have been treated here. And we use this outpatient department, especially for patients with vascular pathologies. That's not an uncommon situation in Germany. There are many hospitals, acute hospitals, who do not have an outpatient department. So it's not only a question of capacity, it's sometimes also a question of strategy, of structure. And you have to collaborate with the colleagues around you. We do not have, in Heidelberg, we do not have it, or maybe yet we do not have it, a structured cooperation with GPs in the area, and also with the resident neurologist specialists here in the area. We participated in the SANO trial, which was run by colleagues from Ludwigshafen and Würzburg. And SANO is a cluster randomized trial within 30 regions in Germany, aiming to evaluate a multidisciplinary network in stroke long-term care. Recruitment has been completed recently, and the follow-up is ongoing. And if this shows us that it helps to have a specialized network for long-term care, then it might change the situation here. But right now we have to deal with this deficit, as I called it. And therefore, in the meanwhile, we handle over the patients again this brochure we have prepared with a Schlaganfall network with the city of Heidelberg, and also within the FAST consortium, we have some material. You see a lot of folders here. It's one per center where we receive or where we send patients. So if a patient comes from a specific town like Sinsheim, he gets a folder for the Sinsheim patients, because there are recommendations for specialized therapists in the area. There is an explanation why the patient is be sent back to Sinsheim and so forth. This is the way how we try to enhance the secondary long-term prevention in our patients here from our stroke unit. So to summarize, I really think that we in Heidelberg have set up an effective multidimensional stroke care system for the Rhein-Neckar region. However, in the times of increasing numbers of patients on the one side and limited resources, especially in terms of staff on the other side, there's a lot of things to do for the next future. We are still not ready for the future. I have shown you that how many physicians are working here in our hospital, and it's more and more difficult to have enough physicians for all the amount of patients we are dealing with. So artificial intelligence, teleneurology, and some more of these things, especially for the radiology department, maybe help us to improve stroke care in the future. And with this final word, tusen Dank für den Aufmerksamkeit. And I wish that we could have some discussion. Therefore, I stop my presentation right now and hope that you can see me on your screen.
Thanks a lot, Peter. I'm just, as I suspected and thought, I'm blown away about what you're doing in Heidelberg. And I think the people in the room here now understand why I ask you all the time about stuff when I don't know what I should do. I'm really excited. Could you? We had some talks about the monitoring aspect of the stroke unit. And you told you have 20 beds and all are capable for monitoring. 16 beds being stroke monitor center, stroke unit beds, and 4, I think, semi-ICU beds. Are there differences in the monitoring? Could you please?
No, it's just a formal difference. If you stand in front of the bed, it looks totally identical. It's not always the same bed. An ICU bed or a semi-ICU bed can be in room number 4, the bed on the window, and the next day it's on the room number 8 and on the door. So it's just an formal diversion. It's nothing real. So therefore, I say our stroke unit has 20 beds, and all are equipped identically. It's just a question of the calculation of the staff size. So it's nothing for the patient, and the patient does not recognize if it's a so-called stroke unit bed or not.
Perfect. Could you make a comment? What do you have as monitor system? What possibilities do you have as monitoring options for patients?
So what we regularly do is we do an ECG monitoring. We have also a system who helps us semi-automatically detect atrial fibrillation, which is run offline. So the monitor data are transferred to a company, and on the next day you will receive an email with a PDF if they found hints for atrial fibrillation. We do oxygen saturation. We do blood pressure measurement. At least every 2 hours. Directly after IV or EST, we do it every 15 to 30 minutes for sure, but usually it's done every 2 hours. The nurses measure temperature every 2 hours. The nurses looks into the pupils every 2 hours. And we also look for the vigilance of the patients. And we can do, but certainly we will never would do, I would like to do this in 20 times simultaneously. We can do intraatrial blood pressure monitoring. But you know, then you get a lot of more alerts, and you have to react much more than when you measure the blood pressure only every 2 hours. Therefore, it's limited to, let me say, 3 or 4 patients simultaneously. But you know, it's not routinely necessary to measure intraarterial blood pressure in a standard stroke patient.
Thanks. I agree. You could use the last 10 minutes to ask my question, but an opening question for you here in the room as well. So, are there questions in the room? Anne-Hege? There's Charlotte.
Thanks very much, Peter, for giving us your experience. So just regarding the stroke unit beds, is that only for stroke patients, or do you have stroke mimics also in these beds? Because then I think
certainly we have a lot of stroke minutes. We have around 10% of stroke mimics. I showed you that the ICD code from the admission coding, not from the discharge coding. But you know that you have to make the same work for the stroke mimics until you know that it's a stroke mimic as you have done for the stroke patient. So regarding workload and the on-the-force, it's identical.
And experience it's often more work with the mimics than the stroke patient.
That's true, because usually you have to do an MRI scan, which we do not routinely in every stroke patient. Also not in every stroke, in every TIA patient. I'm very aware about the discussion that you need an MRI to define that it's a TIA. But we do not do it in any case. But to rule out that it's not a stroke, certainly you need an MRI. So sometimes you have to make more for a stroke mimic than for a real stroke. And that's for, yep.
Sorry, one more question. That was regarding MRI, because this morning we had a talk by the neuroradiologist defining diffusion dated lesions as dead tissue. And for us, it's a bit, we've had this discussion a lot with our neuroradiologist. This is a bit far beyond your Heidelberg experience, but this is a bit more, what is your opinion on this? But this could be a completely different talk, but based on your algorithm, you don't
the elder I get, and I show you 2 slides from my portraits, the more I have the idea that neuroimaging is not real. It's just a hint. And especially if you do a multi-parameter CT perfusion, you always, as a neurologist, have to combine this with clinical information. And especially in very early times, so in the first hour after stroke, if you do an MRI with all those sequences, sometimes if you repeat the MRI, the diffusion lesion is smaller or sometimes gone. Very problematic, it's in the brainstem. The patient could have a severe hemiparesis and a negative MRI. And on day 2 or 3, then you find the pontine infarction in the MRI. So as I mentioned, the older I get, the more critical I'm in analyzing MRI images or CT images as well, and always like to combine with clinical information.
Thank you very much.
We are definitely in advantage as compared to the radiologists who only see in the dark rooms these images and know nothing about the patient.
Thank you very much. That we are very much in agreement with me and Eric.
So I'm lucky.
Thank you so much again, Peter. It was very interesting to hear about the amount of stroke mimics. Maybe you could also comment a bit more about the triage, how you end up with 10% in your bed, and I have 2 more questions. Maybe to take the triage first.
I can look in my data. I guess we have to count the number of stroke mimics for our certification process. So we look every year how many non-stroke diagnostics we have on the stroke unit. For our situation, it's a little bit complicated because, as I mentioned, 4 of the beds are formally not for stroke patients. So it's a little bit more difficult, but it's around 9 to 10% where we treat the patient initially as a stroke patient. And when we then found, okay, no, it was a seizure, which is the most common stroke mimic, or it was a migraine. And we now have a patient on the stroke unit right now. It's a 70-year-old female. She had an aphasia for 3 days. Anything was normal. The MRI was normal. The EEG was normal. The CSF exam was normal. She had no headache, no migraine history. So I just say because she had a definite aphasia for more than 1 day and the MRI is negative, I'm quite sure that it's not a stroke, but I don't know what it is. I treat her now because she had a lot of risk factors, I treat they're very comparable to a stroke patient besides the anticoagulation. However, these are a couple of patients, and again, the most relevant are focal seizures and migraines. And certainly a lot of patients where we would say it's psychosomatic. But it's difficult. We train the patients in reacting to stroke symptoms, and then comes a 25 young nurse from the psychiatry department with aphasia and dizziness and weakness and sensory problems. And certainly you will also say, okay, this could be a stroke. Please go to a stroke unit and we have to check. But this is also, I had the impression this is, it's an increasing number.
I just had a question regarding clinical assessment for endovascular treatment. The median NIH is very much the same as in our centers. You have 16 and 13, solo and bridging, and the lowest range was 9 and 7. Do you comment on the mild strokes, the aphasia, for instance, without much more, which you give a lower NIH? Do you sometimes treat them, or do you, or is it 9 and 7, which is the lowest?
No, we treat patients up to an NIH of 0.
Yeah,
it's one of the most debatable questions right now regarding endovascular stroke treatment. There are three things regarding EST which has to be evaluated. One is what to do with patients with major vessel occlusion and low NIH. You do something like a very early secondary prevention. And they are running different trials, and one is led by Professor Nagel here in Heidelberg, together with colleagues from the States. So we will doing the endo-load study, which focuses on such patients. Can they be treated conservatively, or should they got an endovascular stroke treatment? We had a lot of patients who were admitted with an NIH 2 or 3, had an M1 occlusion where we did nothing, and they started to deteriorate 4, 5, 6 hours later. And it's likely, or it's the other way around, it's not sure that the patient comes back to the low NIH if you start endovascular treatment right now after the deterioration. So we, in the meanwhile, before we can randomize the patients into trial, like to do the EST early. And you know that complications by EST is not in any patient, or it's rare, let me say. We have some patients where we later thought, okay, was it really a good idea to do it? Because after the intervention, we had not one M1 occlusion with collaterals, but 2 M2 occlusion without collaterals, which is not better for the patients and not clinically better. but in the most instances, we do not wait for the deterioration right now, but go to the angio suite. And the other two questions, if you give me time to mention that, is what to do with the very elderly patients. So we do it routinely, 80, 85. We do it very often with patients 90, 94, 95. The oldest one was 103. And if I look to the outcome data of the patients above 90, I'm very pessimistic that this is really a beneficial treatment for those really old patients, but we do not know. And from our guidelines, there's no upper age limit. The other question is what to do with more distal occlusions, M3, A2, P2. So I think these are the three questions we have to be evaluated in clinical trials in the next decade or years.
Thanks a lot, Peter. Maybe you have time for just one short final question, if there are more questions in the audience. No, everyone is blown away, Peter. Thanks a lot again for taking your time and giving us valuable insight about the systems organized in Germany and especially Heidelberg. And we surely have to learn a lot about your system, how you structured monitoring. And it struck me at least that you have a lot of resources as well in the acute situation in the ER, having the patient there. And this I know from my time when I worked in this field, that the situation in the ER was different as we often have not the most experienced doctors in the ER. That makes problems as well in the longer term, that we could move patients in the ward or that we could have treated in the ER and sent actually home. I think there are some take-home message we have to discuss. And I really look forward when we're allowed, or if you're allowed to further discuss the Norwegian problems with you, and I'll surely come back to you. Not too long time. Thanks a lot.
Pleasure, and ha det bra.
Ja, det var dagens internasjonale input. Håper dere har hatt glede av den. Videre på med. Nå det tid for å snakke på beina, snakke litt med utstillerne før det blir lunsj her litt. Så har vi en hel masse NSO-medlemmer her. Etter ett så kommer vi til å holde NSO-årsmøte, der alle medlemmer får delta og bli informert om hva vi har jobbet med det siste året. Og jeg vil også veldig gjerne oppfordre dere som ikke NSO-medlemmer ennå, å melde dere inn, som vil gi dere en mulighet til å faktisk få delta igjen.